for patients ranging from ages basically 1 to 101. And unfortunately, many patients who are coming to us are coming between the ages of 18 and 25. So I think it is really relevant for us to understand how to approach this as physicians, have a standardized approach, and be able to provide appropriate counseling for that. Regular disclosures. So basically today, we're going to review the CPSO and CFTC guidelines for prescribing to patients, especially for those under 25. Become aware of some of the concerns that we have for prescribing to this patient population, and hopefully develop some kind of an approach to evaluating and counseling in this patient population. So first off, the CFTC. The CFTC put out this guidance document on authorizing dry cannabis for chronic pain and anxiety back in 2014 when physicians were first put into the role of being the gatekeeper. And they really, basically what they did is they had a group of so-called experts, some coming from chronic pain backgrounds, some coming from addictions, and only one of them coming from a cannabis background or research background. And that was Dr. Mark Ware from Montreal. And after a lot of debate, the final recommendation with regards to prescribing to patients under the age of 25 was the following, and this falls under recommendation 4 as to who cannabis is not appropriate for. So they say under the age of 25, it's not appropriate as per level 2 evidence, which is well-conducted observational studies. And they state that youth who smoke cannabis are at greater risk than older adults for cannabis-related psychosocial harms, including suicidal ideation, illicit drug use, cannabis use disorder, and long-term cognitive impairment. Following that, within Ontario, the CPSO put out their guidelines for physicians prescribing cannabis. And what they said as well is specifically they put a caveat to patients who are under the age of 25, saying that current evidence strongly suggests that children, adolescents, young adults who consume cannabis are at a greater risk than older adults for marijuana-associated harms, including suicidal ideation, illicit drug use, cannabis use disorder, etc., etc. And because of this, physicians must not prescribe marijuana to patients under the age of 25 unless all other conventional therapies have been attempted and failed to alleviate the patient's symptoms. Now, the CPSO informed their decision based on the CFTC Guidance document. And that guidance document was basically informed from a few studies. Some of the studies suggested that, cannabis in youth increases the risk of addiction. And this is absolutely true. It increases not only risk of addiction for cannabis, but for other drugs. In patients who are at risk for schizophrenia, bipolar disorder, it can unmask that at an earlier age and lead to worse long-term outcomes. Patients who use cannabis regularly under the age of 18 have an increased risk of persistent cognitive deficits. And it can also lead to increased social dysfunction, anxiety, and depression. So this is kind of reliving what we are, what we saw back in the 30s and 40s when there was the big political and economic case to be made against cannabis.
Just a quick question: is regular use daily use?
Yes. So the study suggests regular use could be 1 time a week or even several times a month. Now, what we saw back in the 1930s and 40s is really somewhat repeated today, right? We have everyone yelling, "Won't someone please think of the children?" when we're talking about medical cannabis. But what people really are forgetting is that all these studies are not really looking at medical cannabis. They're looking at children and adolescent and young adult use of recreational cannabis. So the studies that they were looking at are very good quality studies and really do support the fact that cannabis use, especially in youth, can lead to persistent neuropsychological deficits in later life. This is one that was a very interesting study. It's the Dunedin Study. It's a prospective study of a birth cohort of 1,037 individuals followed from birth up until the age of 38 years old. And they actually did interviews at ages 18, 21, 26, 32, and 38 to look at their cannabis use. They did neuropsychological testing at ages 13 and 38. And what they saw was that patients who had persistent cannabis use, this was associated with neuropsychological decline broadly across various domains of functioning. And all of these studies were really well designed and controlled for education when they did their analysis. And what they saw also was that impairment was concentrated among adolescent onset cannabis users with more persistent use associated with greater decline. So the earlier they were using cannabis, the more persistently they used cannabis, the greater they had neuropsychological decline. And what was interesting is if they used a lot of cannabis when they were young and then stopped when they were older, it still did not fully restore their neuropsychological functioning. There's another study that talks about dependency in youth, and this was a prospective epidemiological study. It looked at almost 2,500 patients aged 14 to 24 and followed them up over a 4-year period. They looked at frequency of use and associated this with dependency criteria as per the DSM-4. They also looked at other psychoactive substances that were used. They found that of the almost 2,500 patients, there were 30% who were cannabis users, and of that 30%, 35 met at least one dependency criteria. So that's much higher than we see in our patient population, but it's also much higher than what we see in the adult use population, which is generally quoted as being about 9% tolerance, dependence, and addiction of cannabis for people who are using cannabis for adult uses or recreationally. What they also saw was that there was a much higher dependency in the higher frequency users as opposed to the low frequency. So in essence, what we have is what the College of Physicians and Surgeons, what the CFTC tells us with regards to cannabis being a risk for dependency, for neuropsychological harm is accurate. But what they don't look at is the fact that the information that we are extrapolating from all these studies is really looking at patients who are using cannabis for recreational purposes, and it is not looking at it from a medical perspective. And the people who are using cannabis for medical purposes are obviously using cannabis in a very different manner than those who are using it for recreation. Their patterns of use, the frequency of use, the quantity used, as well as the actual cannabinoid content, especially with regards to THC, is vastly different. What we also know is that cannabis that is being used for recreational purposes over the years has been selectively bred to have increasing amounts of THC to the detriment of CBD and all of the other cannabinoids. So there's even that much more harm that can be associated with using cannabis recreationally at a younger age. And we really don't have enough information to say what the true effects are for using cannabis medically, which is more often used in much lower quantities than people who are using cannabis for adult purposes. There is emerging evidence nowadays with regards to the long-term impact of using CBD oil in younger patients, pediatric patients especially. And this is showing actually improvement in long-term cognitive function. So that's something that's really exciting. So basically, my take from all of this is that really we need a lot more research to inform CFTC and CPSO recommendations. What they're providing us today is a knee-jerk reaction to say that cannabis is bad. It's touting the party line without actually having any real data to rely on. They're taking data from something that is not meant to be used for medical purposes, re-engineering that for their own political or other purposes. Yeah.
Yeah. Do you know if any of the studies control for pre-existing conditions?
Oh yeah. Yeah. Many they do. So there's no doubt about it that recreational use of cannabis, especially most likely high THC, is going to lead to some type of long-term negative outcome. Probably a lot of what is reported in the media and by our regulatory bodies is overemphasized and is not a lot. There's no studies that really compare this to other drugs as well, coffee, alcohol, cocaine, or anything else. But in and of itself, it's a drug. It is something that is a foreign substance into the body, and it is something that is going to interact with the developing brain. We know that. That's not something I think that we can really argue too much about. What we can argue, probably very well, is that medical use of cannabis is very, very different from adult use or recreational use in the adolescent and pediatric population. Yeah.
I just wanted to clarify that I believe you mentioned the prospective study that was in the 70s.
Yeah.
So that date that the study was published is now 18 plus years after the ad was collected.
No, they were born in the 70s.
You were born in the 70s,
Yeah.
so it was published sometime after.
Yes.
Okay.
Yeah.
Is that the New Zealand study?
No, I think it was the Australian study. Yeah. Either way, I mean, they're not great studies, but it's what we have, right? And unfortunately, the regulatory authorities had to make some type of recommendations on whatever evidence was available.
Do we know what the legal age is going to be for recreational?
So for recreational or adult use, the task force on legalization for for cannabis recommended a minimum age of 19, stating that the provinces are able to raise that if they so desire. So every single province may have a different legal age for cannabis. Probably Quebec will have 18 in line with their alcohol. Yeah. And
So how do you feel about, they're so against or don't recommend, do not prescribe at the age of 25, but they're about to open it up freely for those between 18 and 25, right? So
The purposes are different, though.
yeah, so the purposes are completely different, and what the government is doing is they're really taking a public health approach. So they're going in with the idea that, look, we're legalizing cannabis. People are using cannabis anyways. We're not going to endorse using cannabis under the age of 25, but we're certainly going to make it legal so that it's safe, so that they are restricted from using high concentrated THC products like dabs, shatter, butter, wax. We're also going to do a strong push to educate the public about the potential dangers so that at least they can be aware that if they make the decision to use cannabis for recreational purposes, they'll be aware of the dangers. Very similar to cigarettes. Cigarettes are legal, and you should never be using them, but there's a strong public health approach to try to minimize harms that are coming from that.
And quash the black market. So
Yeah, and squash the black market. So, from my perspective, if you're old enough to vote, you're old enough to drive, you're old enough to go to war, you should be old enough to make the decision in order to either use cannabis or not. But the government does have a duty to at least inform and provide as much information either through public messaging or through physician education or through any other means to at least educate whoever is young and thinking of using cannabis about the potential dangers and harm. And they're probably going to do the same thing that they did with cigarettes and try to make it as uncool as possible so that, it's not going to be something, oh, I'm going to go smoke a joint, but, if you're going to smoke a joint, there's going to be a big label and pictures showing how uncool and how unhealthy it is for you.
Once they see their parents, it's not going to be cool anymore.
Exactly.
So, your last statement and your further research,
Yes.
who's going to take that on?
Well, I think we're doing it collectively in a way, because what we're doing at the cannabinoid clinic is we're collecting a lot of information. We do see a lot of patients who are under the age of 25 who are using cannabis, who are getting positive results. We're following along their progress, their social outcomes. We're not doing neurocognitive testing, but these are studies that can be done, and it can probably be done in a similar manner to the Dunedin Study at a population-based level within Canada going forward now that cannabis is legal and that we know exactly what these people are using.
And do you think the CPSO and the CFTC will look at that? And
Not for a long time.
Yeah.
Not for a long time. As you know, CPSO are very slow to move and change their decisions. So I think, when our generation becomes leaders within the OMA, CPSO, CMA, maybe things will change. But for the next 5-10 years, I don't see anything significant moving forward. And, we know that people are using cannabis and being referred to us for consideration of cannabinoid therapy for many different medical conditions. And fortunately, a lot of these medical conditions are chronic medical conditions that are associated with age, but at the same time, there's unfortunately a subset of the population that are young, that are living with horrible chronic diseases, either born with genetic defects or have suffered catastrophic events. And these are people that we really do have to come to grips with and figure out how to deal with at a clinical level. Now, for myself, I think it is important that we try to approach patients who are under the age of 25 with a shared clinical approach. I do think because of the medical legal risk, we have to proceed with caution when evaluating and agreeing to treat patients under the age of 25, but I feel very strongly that whoever is referred to us deserves at least a consultation. There are other cannabinoid clinics, and actually I would call them cannabis clinics or pot clinics, who will actually not even see a patient because they are under the age of 25. And I don't think that's fair. There's a lot of people who are under the age of 25, under the age of 18, under the age of 5 who might really benefit from cannabinoid therapy. And if they're using cannabis already and they're using it inappropriately, they also deserve a chance to have a consultation with a physician who is aware and able to actually talk intelligently about cannabis, to talk to them about the potential risks. Now, the approach that I take when looking at patients under the age of 25 is really the same as over the age of 25. There's nothing really that changes. There are some exceptions, though. I am much less willing to proceed with what I call a harm reduction approach. So those patients who come to us who do have pathology, but say, Doc, I'm more naturopathic, I don't like pills, I just want to use cannabis, I've been using it, it works for me, so just give me cannabis because I'm not going to take pills. And for an older person who, 40, 50, 60, okay, you know what? I have no problem. I'm going to provide you a prescription because it's working. We're going to reduce harm. We're going to limit the consumption. We're going to give you some education. Make sure you use a vaporizer. Or even those people who are going to say, you know what? I'm going to use it anyways. I'm not going to use any pill that you give me. Okay, I'll give you a prescription. But when it comes to patients under the age of 25, because of the risk of using cannabis inappropriately and because of the possible neurocognitive long-term risks associated with it, as well as for the medical legal risks, I'm not willing to do a harm reduction approach. Obviously, just like with any other patient, we have to weigh the risks and benefits. I've seen over 250 pediatric patients for treatment-resistant epilepsy, and I have no qualms whatsoever about providing them CBD oil. And people say, oh, but doctor, what about the possible long-term neurocognitive deficits that cannabis can cause? Well, first off, it's the THC. Second off, these patients' brains are not normal to begin with. And we're looking at patients who are most often palliative, who do not have a long life expectancy, and we're looking at improving their quality of life as opposed to making sure that they're going to be able to go to Harvard. So for me, this is such an irrational, knee-jerk response that we really have to, remove ourselves from just saying, oh, I have to follow the CPSO guidelines and not get in trouble, as opposed to actually doing what's right for the patient, what's right for the parents, what's right to be able to actually improve their quality of life. With patients under the age of 25, I also find it really, really beneficial to get collateral information. So if a patient comes in either with their parent, their spouse, their girlfriend, a friend who is able to tell us and give us that information to say, you know what, he was really terrible before he started using cannabis, but since using cannabis, things have changed around. He's going to school, he's or she is, able to go to work. This is information that I find extremely valuable. Also, within this population, I also have to be very certain that if I am providing medical cannabis or if they're asking for it, to make sure that there's no ulterior motives. So make sure that they're not someone who's working within the gray market or black market cannabis industry. There's a tremendous amount of people who are working as growers, as trimmers, within dispensaries, who really just want to get a prescription for cannabis so that if they ever get caught up in one of the raids or arrested, that they can show the cops, hey, I have my legal card, this is fine. There might be some other social issues or legal issues to say, you know what, maybe they need a card in order to prevent any harm coming to them. And there's also, unfortunately, a lot of people who are coming to us referred by their family physician for non-specific psychiatric indications, for non-specific anxiety, non-specific depression, who have never seen a psychiatrist, who have never seen a counselor, who have never had CBT, who have never done the actual work that you need to do, and who are self-medicating with cannabis. But as we were talking about before, perhaps they weren't self-medicating with cannabis. Maybe cannabis is the actual cause behind their depression or anxiety. So if a patient comes in, non-specific psychiatric reasons, requesting cannabis, already using cannabis, or even if they've never used cannabis, I will say, listen, you know what? You have to go back to your doctor, get a referral to a psychiatrist. I need diagnostic clarification because I'm not willing to make the diagnosis. I'm not willing to provide you a prescription for cannabis for an indication that is not something I would usually give to people who are over the age of 25.
You take that approach at any age?
Not any, I really do try to understand a patient's motivation for using cannabis, and I think that the topic of cannabis prescribing in the worried well is a completely different topic that we should probably explore at a different dinner. Is that fair? Like that's too big of a question. So history of present illness, to ensure proper diagnosis and management. If there's any concern, send the patient back with specific recommendations and say, you know what, this patient hasn't, like I had a patient the other day, a 16-year-old who was referred to me for anxiety and fibromyalgia. When I did a proper history on her, she had a history of intussusception, hypermobility, and there was really no signs or symptoms of anxiety, depression, or maladjustment. She was a perfectly lovely lady. And she had chronic pain for sure. And it struck me that this patient who's 16, who also has a family history of chronic pain issues, very likely has Ehlers-Danlos syndrome. And I explained this to her. I said, you know what, you're not crazy. You don't have necessarily anxiety and depression. And she was like, I know, that's what I've been telling everyone. So I explained to her what my clinical suspicion was. I sent back a note to the patient, to the referring physician saying, listen, I think she needs more investigation. She may not have had the appropriate specialist workup. I recommend going down to Dr. Gordon at the Wasser Pain Clinic for genetic testing for Ehlers-Danlos syndrome. So, you know, really, like, just because a patient is referred to you with fibromyalgia or anxiety doesn't necessarily mean that's the right diagnosis. And I truly think you have to, you know, always look at a patient with fresh eyes. Good cannabis history is imperative, especially when patients are coming to you already self-medicating. It's really important to know, are the symptoms that they're experiencing present prior to initiating cannabis or only after? Obviously, this is because we have to rule out cannabis withdrawal syndrome. Cannabis usually makes you happy, hungry, sleepy. The opposite is when you use too much cannabis, you become dependent, tolerant, you get anxiety, nausea, insomnia. I've had so many times patients have come to me, say, oh, I have anxiety, I have insomnia, I use cannabis. Well, stop using it for a couple of months and it will resolve. Obviously important to document all of the other things that we often ask about: employment status, educational status, driving status, legal status. I find legal status interesting to ask patients. Have you ever been arrested? Why have you been arrested? What's your current status? It's really interesting what they end up telling you. Very often I find, oh, well, I was arrested for a grow-up, I was arrested for, you know, or if they were arrested because they always have outbursts because their anger or ADHD is out of control, well, maybe that is a good indication to have cannabis. And just like with our older population, but even more so, I really, really think it's important to identify specific goals that your patient wants to achieve and ensure that whenever you see them, they continue to work towards those goals and they're engaged to achieving those goals. Otherwise, there's no point in prescribing a medication because you're not trying to achieve any specific outcome. I have 3 cases for you that are from patients that I've seen over the past 3 months. This is Mr. Beaky. He's an 18-year-old referred by the chronic pain clinic at the Hospital for Sick Kids, diagnosed with neuropathic pain and peripheral neuropathy, mostly in his right arm, following several operative procedures for thoracic outlet syndrome. His previous medications run the gamut. His current medications include Effexor, Lyrica, Nabilone, 4.5 milligrams total daily, and ibuprofen. He's followed closely by the pediatric chronic pain psychologist and psychiatrist because of suicidal ideation due to uncontrolled pain, not because he has an underlying anxiety or depressive disorder. He's doing all of the appropriate things in terms of other strategies. He's unable to complete post-op physio because of the uncontrolled pain. And his parents are incredibly supportive and aware of the referral that was made to us. And they came along because they have many questions and concerns, especially about the long-term risk about cannabis, and want information on potential risks and benefit of medical cannabis, not recreational cannabis. So he first tried cannabis within the past year, so since he was 17. And it was actually at a suggestion of a friend of his who came over, brought a joint, and he says that on the very first trial, he experienced a significant reduction in pain. He was distracted from his pain. He was able to focus and concentrate on his schoolwork. Since then, he was using it irregularly, and it was his parents who were actually dispensing it to him. And he would be using it more regularly, but he was worried about running out of cannabis because he does not have a consistent and reliable supply. And he only uses 4 to 6 inhalations at a time until he gets an effect. And he had very specific goals: restart physiotherapy, go back to school, get back to a normal life, and over time, hopefully get off some of his other medications. So this is a patient who I think, is 18 years old, CPSO and CFTC would probably say, you know what, this patient is an appropriate candidate. He has tried everything, he's failed, he's using it appropriately. I have no concerns in prescribing this to him. He has a complete support of his parents. I prescribe it to him. Does anyone else have any concerns that would actually limit you from prescribing cannabis to this patient?
My concern is that you was prescribed opiates before cannabis.
Yeah.
in a young kid like that, like in a condition that doesn't have good evidence.
Exactly.
I'm much more concerned about that.
Well, what's interesting is the Chronic Pain Society, Canadian Pain Society, their guidelines on chronic neuropathic pain has opioids as a second-line therapy and then cannabinoids as a third-line therapy. And I was talking to people who were in on the planning committee for that, and the discussion was incredibly heated when they were talking about whether they should put cannabinoids second line and opioids third, or vice versa. And we know that there's very little evidence to using opioids in neuropathic pain, yet they're part of the guidelines, and they're before cannabinoids, which arguably has more evidence. So you're right, it's a shame, and I think that in the future we're going to see this changing as the evidence progresses.
What was he using? It? What strains was he inhaling?
Oh, he got that from a friend on the street, so it was a high THC.
Yeah, so something like that.
Yeah. So after I saw him, I gave him a prescription. I started him off on an under 12%. It was not as effective as the cannabis he was receiving from the street, so I very quickly increased that to allow him. And actually, like with this patient, because the lag time between getting the cannabis from the licensed producer was so long, we actually had to bridge him with allowing him to go to a dispensary and facilitating that.
I think we've all done that.
Yeah. I mean, and it's such an extreme case.
Just out of curiosity, what's the bridge time? What's the lag in getting product?
Oh, it was about like 4 or 5 days.
Fairly
But it's also, it's over a weekend, and then they have to order. It's just such a ridiculous system.
It is.
But we're not going to get into that now because let's focus. So I have 2 more patients I'd like to present you, very different from BT. And they were both seen on the same day, actually. So this is SP. He's a 16-year-old guy. He was referred by a pediatrician for ADHD and possible autism spectrum disorder. The information I had on the referral was that his great uncle has a history of drug-induced schizophrenia. He's been using cannabis recreationally and reports that he feels that it helps with sleep and anxiety. He was referred to an addiction counselor because he also uses cocaine, and there is no specific diagnosis of anxiety, but he says that it helps for stress because he's going through a lot. When I ask him a few questions, he does say that, last time he used cocaine was a few days ago. He smokes about a pack of cigarettes a day. This is a 16 years old. He doesn't use alcohol, but when he does manage to steal it from his parents' cabinet, he'll trade it for cannabis. And he really had no insight whatsoever into symptoms and signs of ADHD or any of his other diagnoses. When I started asking him about his cannabis history, he says he's been using it for the past 5 years, since age 11. And daily for the past 2 years. He was introduced to it by his brother. He uses cannabis in poppers. Do you all know what poppers are? Yeah, so poppers are the nastiest way that you can use cannabis. It's basically using a bong where you have a small amount or an amount of tobacco, and then over that you have cannabis, so that you get a massive hit of nicotine chased by cannabis. That gives you basically a rush and a high from the nicotine and then a persistent effect of the cannabis. And people get incredibly addicted to the nicotine. So it's prevalent in Northern Ontario as well as Quebec, I believe. And
They do blunts or splits.
yeah, so blunts are often, yeah.
Yeah, it's honestly prevalent everywhere, but mostly in those areas where they're trying to preserve their cannabis and kind of supplement some of that high THC effect with the nicotine.
Yeah.
So they don't want to use as much cannabis, so they mix it into.
Yeah, but they just get more addicted, they end up using more. And so he starts boasting to me that he can use up to an ounce daily, 28 grams. He admitted to me that he actually had a break and entering where he was stealing someone's medical cannabis, and now he's on probation for that. His conditions of probation were including going back to school and not using cannabis. But he continues to use cannabis despite this. He's unable to sleep without cannabis. He's able to focus. He does say he's able to focus on schoolwork and that cannabis keeps him out of trouble, but he's on probation. And, with cannabis, he'll get mellow, hungry, and not get all worked up and get angry. And he, when I asked him, so, do you see any potential harms of using cannabis? He doesn't see any problem with that. So obviously, this guy, 16 years old, psychiatric history, family history, meets almost all criteria for cannabis use disorder, is obviously not a good candidate. And despite my best efforts to counsel him about potential harms, offering him even nabilone to help cut down, to be able to stay in line with his parole conditions, he wasn't interested. So for him, I couldn't even do anything, but at least I was able to provide him some counseling. I was able to support the other physicians who are involved in his care and say, you know what, cannabis is not a good medication for you. And at least provide that expert opinion so that the other physicians can also reinforce that as well. And hopefully, over the long term, this gentleman will not end up in too much trouble.
He's on the road to hell.
Oh, yeah. Yeah. So, this,
Cannabis.
yeah. So I saw him in the morning. My last patient of the day was Mr. KB. He's a 17-year-old. He was referred by his family doctor for ADHD and anxiety. Information I got on the referral from him is that he had a very good psychiatric consultation earlier in the year that really does confirm a long-standing history of ADHD. He had very good trials of Vyvanse, Concerta. He had side effects that caused poor compliance. He also was diagnosed with unspecified anxiety disorder by psychiatry. He has incredible mood volatility, impulsivity, anger, which is most likely related to uncontrolled ADHD, and that's led to problems with the police in the past. No other family history of schizophrenia, bipolar, or anything else. Similar to the other guy, who used cannabis a couple days ago, he says he uses cocaine and MDMA every couple of months, and it wasn't positive in his urine. He's a non-smoker. He rarely uses alcohol. His cannabis history is similar to our previous gentleman, where he started to use cannabis at an early age, around 13, introduced by an older sister. And he's been using it actually quite consistently since the age of 13, and the longest he's gone without is 24 hours. He says he smokes about 3 to 5 joints, very small, with no tobacco throughout the day. And he really believes that cannabis calms him down, allows him to think clearly without his brain going a mile a minute, and it helps to decrease his impulsivity. And as opposed to the other guy, he uses about a gram a day. He said he would probably use more, but his girlfriend doesn't approve, although does realize that it is providing some benefits. He tried to wean himself off cannabis last year, but because of symptoms of ADHD and impulsivity, he wasn't able to completely stop, but he did cut down considerably. On average, when he doesn't use cannabis, he'll miss about 1 or 2 school mornings a week because he does have difficulty sleeping. And he also tells me that he was recently arrested for breaking and entering with one of his friends, which is no longer a friend, for stealing medical cannabis and was caught. But unlike the other guy, this patient reports that his duty officer, his parole officer, and his family all suggested that he consult a physician in order to discuss whether medical cannabis is right for him. So obviously this guy and the previous guy, who are no longer friends, and the other guy was the ringleader, have a similar but...
So the other guy was his friend, huh?
Those were the 2 guys who were breaking and entering into someone's house to steal medical cannabis from Med Release, by the
So
way.
one kicked out.
What?
The friend was kicked out.
Yeah, so the first guy was kicked out. I didn't want to have anything to do with him. But this guy, when I spoke to him, he was much more personable. He was much more self-reflective, and he was able to understand that he had pathology. He had ADHD that got him into trouble, and it was quite clear to me that he was self-medicating his ADHD and impulsivity with medical cannabis. And I also explained to him the potential long-term neurocognitive issues of using THC over a long period of time in youth. And his reaction, as opposed to the other guy, was, oh my God, what can I do about this? As opposed to, there's no problem with it, I'm just going to smoke weed. So I felt a lot more able to actually work with him. And what would you guys do in this situation?
It's a gray area, I think. It's,
Very.
Yeah, this is as gray as
What
it
kind of
gets.
cannabis was he using though? I mean,
He was using street cannabis.
but again, what kind of strain was he using? Does he know what was in it?
No. So interestingly, the strain they were stealing from that person's house was Midnight, which was like a 1-to-1. And they said it didn't do too much to them. Not as good as the stuff that they got on the street.
For me, it's about if I can work with the person.
Yeah.
You're young, you're impressionable. Can I leverage this opportunity to really help you long term? I'm going to have to be a little bit more parental or paternalistic in my approach with you, perhaps. But can I really leverage this? And maybe a little bit of cannabis might help, but maybe I'll get you to try like an SSRI simultaneously and use that as a leverage to help, depending on where he is in that view. If I think an SSRI is approach.
Can you strongly justify, in this case, to the college or anyone else that the pros outweigh the cons? How do you know that he's had adequate trials of stimulants or Strattera or other things like that?
So the psychiatrist recommended, he tried Vyvanse and Concerta, so they did recommend Strattera and another one. So
That could be a negotiated thing. Try Strattera, see how it goes, and if it's not
yeah.
I have a young guy in his 20s who's actually using Concerta for ADHD. He's getting cannabis to counteract the side effects
Yes.
of the cannabis, right? So there's a possibility that this guy could do all right on Concerta and cannabis, right? Like that might be a reasonable combination, right?
Yeah.
And he's doing much better. I mean, he's taking his Concerta fine. he's using his cannabis fine, he's able to work, he's able to concentrate, he's so happy. Right?
Yeah, this guy has a lot more insight. This guy is insightful. The last one was not insightful.
Exactly.
Big
Or he
difference.
plays the game. You never know.
Could be clever.
So, I mean, for him, I have all these.
17, was it?
Yeah, 17, and like when you're in clinic, you don't have the luxury of sitting back, thinking about it, discussing it with your colleagues. You gotta make a decision on the ground. And part of me always has the CPSO and the CFTC in the back of my mind. And I know that this guy hasn't tried everything, although he seemed like a good kid. And he seemed eager to want to help himself. But I figured, you know what, he's using high THC content. Nabalone might be good to help with his withdrawal symptoms. It might be beneficial to help with sleep at night and to help him wean off of the cannabis and at least give him an opportunity to potentially chase down some of the other recommendations that were made. And when I presented him about the option of Nabalone, he actually jumped on it. And I prescribed it to him. And I was supposed to have a follow-up with him last month, but unfortunately he didn't show up.
The other guy stole his Nabalone.
I wouldn't be surprised.
Or he sold his Nabalone.
Yeah. Well, Nabalone doesn't have any street value,
No, really not.
except I think in the prison population. But as a street drug, it's really not a drug of abuse. So it's not something that people look for or try to score.
You think about like a high CBD product,
I don't think it would do anything.
just because he's been using the THC stuff.
No, because from my experience with patients with ADHD, they need something that's high in THC, really just to calm their brain down enough so that they can focus and work on the same level as all of us.
So would you choose more of an indica or sativa?
Indica. Yeah. Otherwise, it might ramp them up too much. So just to follow up, while cannabis is relatively contraindicated, there are many patients under 25 who may benefit from medical cannabis, and I'm going to put the focus on medical, not recreational. Harm reduction strategy in this population really is not a reasonable reason to prescribe for the patient's best interest, but also our best interest from a medical legal perspective. It's really, really important in this patient population to take a good history, including a detailed cannabis history, psychosocial, and medical history to make sure you're treating the right thing. And the patient has to do the work as well. If they think cannabis is going to do everything, then I would not recommend. Potential harms of cannabis are real, as we were talking about before, in terms of cannabis use disorder, neuropsychological impairment over the long term. And if we are prescribing cannabis, obviously, just like in the older population, start low, go slow, start off with lower THC, and then work our way up over a period of time with specific objectives and goals in mind. That's all I got.
Topics for Mike too.
Yeah.
Oh, thanks.